separating the fact that if you don't get an EGFR inhibitor, for instance, either first line or just for a few cycles, really what harm's being done. And we have to remember in RAS mutated patients, for many of the studies, there's a pretty good trend towards harm if they're RAS mutated. And then not to mention, of course, for a 1.7 meter squared person, the $5,700 cost. At some point we are going to have to be thinking about the costs of these things. So from my standpoint,
but I get a 70% response rate, right? I want a response in this woman.
Absolutely, and actually, these are the kind of people where I might use FOLFOXIRI or FOLFIRINOX, because I think if you're going for response, and it is really important to be clear about what are the goals of therapy, because I see people who have absolutely no symptoms get triple therapy. And I'm sort of like, are we trying to make the CAT scan look pretty, or are we trying to prolong the survival of the patient? And then you sometimes see a less aggressive approach where a response could be really helpful for someone who's having pain or about to obstruct. I agree with you. I don't like stents. Just like to get the chemotherapy going.
Well, I worry. Those are the ones that I've had perfs lately.
So
that's the only reason they work great, but I worry about perfs down.
Absolutely, and you certainly wouldn't want to give, for someone who might have to have emergent surgery, you do not want bevacizumab or ramucirumab on board. So that's something to think about.
So I gave her FOLFOXIRI through a peripheral line because apparently you can't get a port over a holiday weekend or a PIC in our hospital, so that's just a shout out there. And then waiting on this because I wanted that response to get it. Back to Wells's point, this is a little off our main topic, but I've been thinking a lot about this issue of regimens and proven benefit where we decide that it's too toxic or it's not the right thing to do. And I think the two examples is the FOLFOXIRI Bev study, the TRIBE study, which showed a survival response, PFS benefit, but was toxic, so we don't give it, even though it was a positive study. And then the same thing is true for left-sided RAS wild-type colon cancers, where we have really big deltas in those retrospective analyses, but we say we don't like the rash. And where do we get off being so paternalistic or maternalistic and saying that, we're going to not offer you this proven survival response rate benefit because of toxicity? What do you think about our behavior there?
Well, I think that oftentimes we do take into account what the goals of care are. And I think that if, again, response rate is a consideration, and especially if I have a KRAS mutant patient, I would never hesitate considering FOLFOXIRI. We are very well versed on how to manage FOLFOXIRI and FOLFIRINOX today.
Even in that Wells asymptomatic patient, I almost never think to give that, though.
I think that in asymptomatic patients, because again, we have so many lines of therapies and so many good clinical trials that we don't want to disqualify potentially patients to participate and new agents coming on board all the time. I think we sometimes, again, worry that patients will become, again, resistant in time and they may not have access to something novel down the line.
Yeah, that we spend it all too soon. But even though those studies say that there was an OS benefit, that's what I struggle with. Some of this to me is also it's just complex for the practice to manage one of these regimens, whether it's the additional rash toxicity or the myelosuppression and diarrhea of the triple drug therapy. Well,
yeah, just to make the point that in many of those studies, and actually in pharmacy databases, and I think one of the nice things about all these computerized records is hopefully we can get data from tens of thousands of patients, but many patients don't get second-line therapy. When they look at pharmacy databases and when they look at those trials, a lot of patients don't get second-line therapy, and at least in my practice, everyone gets second, everyone gets third, pretty much, unless something horrible happens. So one of the reasons I feel comfortable with it is because I know that, at least in my practice, people are going to get exposed to all the drugs. I don't have to worry that they're not going to get any second-line therapy. And in many of those trials, over half the patients got nothing else. So yeah, if your plan is to give nothing else, you should probably give that. But short of that, I think you can feel comfortable being a little bit more doling it out in terms of the side effects and be a little more judicious with the drugs.
So I have to say, John, that some of us have actually endorsed that data. So I mean, to me, for 5 months difference in overall survival for left colon, with anti-EGFR therapy is something important. And
It's hard not to leave that on the table, right?
No, you don't. And you discuss this with patients, and patients are receptive. I mean, and let's face it, they're going to get that anti-EGFR at some point in their treatment. And the truth is, even when you implement it in the first line setting, a lot of times you're not pushing it necessarily much more than 6 months, because a lot of issues may arise, hypomagnesemia or some skin toxicities that the patient want to do without. And so maybe that downstaging is important. And so our practice now has moved to basically stratify by left, right, and if it's a left RAS wild type, BRAF wild type, they get anti-EGFR in the first line setting.
You know, you bring up that question because there's a study being presented here. If you started with, in this case, panitumumab in front line, what do you do in the maintenance setting? Just kind of keep plowing along, or do you switch over to the sort of VEGF-based, you know?
Do you want a $6 drug or a $6,000 drug as your maintenance
Well, what's
approach?
the $6 drug?
5FU.
Well,
Glucovorin is 61. And you're right, you have to
well, I think the data's with CAPE, I would say, so that's not a cheap drug. And the data's with BEV, too, which is not cheap drug either. So, but do you maintain the EGFR therapy through that, or switch? What's your thought on that?
I do maintain if it's tolerated by patients. I mean, like you mentioned, the VALENTINO trial showed a PFS of 13 months versus 10 months, and that was statistically significant.
So you drop the chemo and just give single-agent EGF?
I mean, I use FOLFOX still in my first line, and I drop oxali after 4 months of treatment, and then they're maintained on fluoropyrimidine and anti-EGFR. Now, I do switch biologicals if they have a problem with anti-EGFR toxicity. So if I see the magnesium level is dropping and I can't keep up with the replacement, or it becomes a nuisance to the patient, certainly I have no problems at all at that point dropping anti-EGFR and switching to fluoropyrimidine.
You know how I've solved hypomagnesemia?
No.
I don't check it. Just it goes away. It's no longer a problem.
But
Just don't do the. You like that, Brent? That's a good strategy.
No,
Just don't look.
But I'm telling you, I've seen some 0.4s, John.
Yeah,
so.
but yeah.
Valentino, though, looked at continuing panitumumab plus 5FU versus panitumumab. So it was the 5FU is what gave the 3-month benefit, not the panitumumab.
Yeah,
So-
but I have to say 13 months is quite impressive
It
as a
is. I agree.
PFS, so there's a signal there.
So what you're saying is you are a FIRE believer and not a 80405 believer.
Well, I mean, 80405 left colon RAS is
delta.
not that far from FIRE3.
Yeah.